Ladies and gentlemen, thank you very much for your continuing attention. We will start with our next panel. Our next panel's topic is Caesarian section crisis in Kurdistan region. I would like to welcome our moderator, Dr. Chiman Akrey. Welcome, Doctor. Our panelists list Dr. Haider Tawil. And next, Dr. Mahabat Sabar Ali. Last but not least, Dr. Shler Faiq. Dr. Chiman Akrey is a National Public Health Officer, WHO Erbil. Dr. Haider Tawil is a Reproductive Health Program Analyst at the United Nations Population Fund. Dr. Mahabat Sabar Ali is the Head of Gynecology Department of Maternity Teaching Hospital Erbil and Trainer and Determinant of OBGYN Department, Kurdistan Board of Medical Specialists, KBMS. Dr. Shler Faiq is an OBGYN specialist, Manager of Suleimaniya's Maternity Hospital. Welcome. You may take the floor, Dr. Chiman. Thank you.
Thank you. Okay. Good morning, Bent and Bash. I am Chiman Akrey. I am a public health officer now with WHO Erbil, Iraq. I was working for Ministry of Health in Kurdistan region as Director of Public Health and Food Safety before joining WHO October last year. And just before that, I completed 2 years residency in obstetrics and gynecology. And I had more than 15 years of experience in the public health and nutrition. I am very privileged and honored to moderate this important topic about Caesarian section that are overwhelmingly prevalent among pregnant women in Kurdistan region with an overall rate of 41.8%. I hope today, with the extensive experience of our panelists and with the professional interaction of our audiences, we will be able to reach a set of solid recommendation and suggestion to tackle this issue in a best possible way for Kurdistan region. So I would like to start I want to welcome the panelists, and I would like them to introduce themselves shortly. Thank you. Please, Dr. Haider.
Good morning, everyone. I am Dr. Haider Al-Tawila. I am medical doctor, graduated 1990, and with endocrine background by practice and training. Also that I have master's degree in health administration. I'm joining that UNFPA Iraq country office since 2013 and working on reproductive health program. Thank you.
Thank you, Mahabat.
I'm Dr. Mahabat Sabar Ali, specialized OBGYN, and I graduated as specialized 2009, and 2010 I am working as gynecologist in Tertiary Center Maternity Teaching Hospital in Erbil, and in 2016 I am a head of Department of Obstetrics and Gynecology, and until now I'm there.
Thank you, Dr. Mahabat. Dr. Shler, please.
I am Dr. Shler Faiq. I am an obstetrician and I am the manager of Maternity Teaching Hospital in Suleimaniya Hospital since 2008.
Okay, thank you. Thank you for the panelists. And actually, our session is supposed to last for 50 minutes. We will give like 7 minutes to the panelists for the question that I will direct to them. Then we will have time for a question from the audience. And well, I just want to say, when I was first contacted by the KS board to moderate this session, it just came into my mind. I just went back 70 years back when I was in labor in one hospital. It was 1 a.m., and the obstetrician was asking me, okay, decide, shall I send the anesthetic team home or you will operate? I was a patient. I was not a medical doctor, actually. So that's why Caesarian section could be a very important life-saving procedure for both mothers and babies in certain medical conditions. And however, unnecessary Caesarian section might lead to increased medical risk for mothers and the neonates. That's why WHO has set a Caesarian rate of 15% and less to balance the risk and benefit of Caesarian section for the mother and the neonates. And as I said at the beginning, based on the MOH statistic 2020, the overall Caesarian rate for Kurdistan region is 41.8%. For the public hospitals is 29.2%, and for the private hospitals is 86.4%. Actually, the highest rates are in Suleimania, then it's come Erbil, and then the Hook. But this is for the public. For the private, I don't have data for the Hook, but again Suleimania, then Erbil. With the increasing number of Caesarian section, which become commonly increasing, in, not only in developed countries, WHO announced a statement that emphasizing that Caesarian rate up to the rate of 10%, it will decrease the number of the neonatal and maternal deaths. But there is no evidence that Caesarian section above 10% will improve the maternal rates data for maternal, for the data in general, maternal data. So with this, I want to stop here, and I would like to go to my panelists to start the question. Thank you. So with this, I would like to welcome you again, and I want to start with Dr. Mahabat. And I was honored to work one day under her supervision. Very strong personality, very kind heart. So I would like Dr. Mahabat, with this introduction, why should we be concerned with these rates? What these rates are telling us? What's going wrong? Thank you.
Okay, thank you. The name of the panel is crisis.
Yes.
Really, it's crisis. I'm talking about our locality and on general. I think most of audience here they are doctor, or not all of them. I want to explain my talk by Kurdish language because we are here. Our aim it is to put the plan for this increasing rate for this abnormal increase in the rate of Caesarian section. So. براسي كرايسيسا يعني سيزاريان سيكشن بو درجة زيادة كردية كرايسيسا لو كارثاتا كاتاستروفيكا لبروي أجروها بروا ما بنلج كذا دنيشين أفرتك لكردستان نامينه سكاري ليترسي نبي. أفرتك لكردستان نامينه سكارتشي لا سكينبي لبر من داربوني بنشتر جري. واقع كواحة ديارة دبينين بتاعي خمان زورة زوريشة يعني بالرجال زياد بندايا لولاتان الدنيا أما وكبابلين لوي باشتر بس موضوع كيفين لهمو دنيا رجال Caesarian section زيادة كرديا همو دنيا globally increasing the rate of Caesarian section لولاتاني بيشكوتو لولاتاني ولات السيام الوطني تازر بيشكوت وكان بس أول رجاء همو كاس خلقان يعني ل 2005 خريك إيش لو ده كان أو ترند كودا وزن وكوكو هول دريبو كم كرنوي رجاء مردني داي كان أو ترند أو إيشاش ذكريبو كم كرنوي رجاء مردني رجاء نشترجري مدالبون بنشترجري كواتا بس لولاتي ما أو رجاء برو زوربونا أو مسؤولي سرتشيشة طبعا ستار لنا بزيش نخوش خانة تابتي كان بلان دناني بلاني بريك لو أو ظاهرة ريك بكريتوا أول لا اشتاق لا نقطة مهمة كان لو تشيء أجري ما باز بكين لو نلين أو وضع يعني بسيزرين سيكشن زيادة كده أما نبكو بزيش جي نشتري أفرتها ومداربون بسبوري أفرتها ومداربون نشتري ئەنجام دەدەین هەموو ینی ڕۆژانە لەوانەیە هەفتانە بەس مانای نییە ینی بەو ڕێژەیە زیاد بکرێ کەواتە ئەمە لەگەر وەینە سیزەریان سێکشنی ناپێویست ئەنجام نەدرێ شتێکی پێی دەگوترێ نەن مێدیکەل ئیندیکیشن سیزەریان سێکشن یان پرایمەری سیزەریان سێکشن تەسەوڕ کە نەن مێدیکەل ئیندیکیشن سیزەریان سێکشن ڕێژەکەی لە 150 يعني معناه إيش معناه يقل دو أفرتي كمن دالي دبي بنشتري من دالبو من دالي يعني بس سيزيريان سيكشن من دالي دبي كوات فعلا هو كرايس وكارثات دبي إشي لبوكري يعني ناكري تشكوا يقل بوينت كان يشتي نخوش بلانك داندرا يعني كو رين ماي بكري نخوش دست نشتري بينا قطري يعني بتفاوي لونا دو ورقة سي ورقة لو بخين دريتوا همو ماكا كان كاتي نشترجري دواي نشترجري ماكا دريش خيانة كان بارنا كم هيز نخوش لك قدر زي رجاي روشنبيريش زور أستي برز بي لا يعني تندرستي كي أنا لا يعني أو تندرستي بو رجاي بك أجد دكتورة كباتي هناك أملو وادلين تنكا الهم الدنيا بداتاي ذهاني رجي كبين براورد بكين من دالبون بنشترجري رجي مردني دايكان أجر أو 6 مليون بي أو 16 مليون أجر زلطي سينج أو استقاد زياترة ومشاكل كاني ولا شيء من دالو كلا نشترجري دو مسيم دارو ددا سيقات ودقات وبنزاقاتا فكواتا أو سبجكتا بابلين أو بابەتە زۆر گرنگە لە ئێستاوەڕە مەلەو پەنەڵێتەوە بووین ئیشی بەجددی لەسەر بکرێت ئیشەکە وەکو ئەمە لە زۆربەی پەنەڵەکان باسی چاکردنی سیستەم کرا باسی ئەوە زۆر سیستەمی ناوێت دەبی وەزارەتی تەندروستی پلانێک دابدرێ وەکو ئەمە با بڵێن لە نەخۆشخانەی لەدایک بوون لە 2010 هەتا 2013 ڕێژەکە لە 32 لە سەتا بوو گەیشتن 2035 لە 2013 و 14 گەیشتە 38.5 کەواتە هەستمان کرد ڕێژەکە زۆر بەرەو زیاد بووندایە ئەمە هاتین لێژنەی نەشتەرگەریماندانە ئەو لێژنەی لۆ ڕازامەندی نەشتەرگەری نەخۆش دوو پزیشکی پسپۆر حاڵەتەکەی تێگەێنی ئەگەر پێویستی يعني پێویستی بە نەشتەرگەری نەبوو تێدەگەێنرێ و بە شێوەیەکی سروشتی دەبی کە ئەو ڕێژەیە ئێستا سەتاسیە لە مستشفای بەس ئەوە بە بەراورد بکرێ ئەو حاڵەتەکەمان بە تەواوی لە کوردستان لۆ چاناکە چونکە ئێستا بۆ باسمان کرد ترێندی ئینکریزی سیزەریان سێکشن ڕێیت یعنی بەڕاستی کارەساتە مستشفایەت دروست دەکرێت بەس لە بۆ خاتری نەشتەرگەری منداڵان یعنی financial supporti بس نشترجني من دالبونا نهكري وزارة التندرستي بيدنج بي صندوق بيجيش كان بيدنج بي كمال كان بيدنج بن دبي أو يعني براسي زور بلاني دابني أو بيوستي سطع نهتي بيوستي بسيستم نيا بيوستي بقرار decision maker بيوستي بداناني كوميتي ريكوبيكا وكو ما كردمان الهم الدنيا شو كرايا يعني هم الدنيا هو إيشان كردي كواتا لبر هندي أما ما بدك جرينجل لبر أو بوينتاني كباسم كرت فرص باس
زور سباس دقيقة دارم okay thank you my second question I will direct it to Dr. Schiller Dr. Schiller what do you think what are the risks that lead to this high rate of Caesarian section in Kurdistan region and particularly that you are from Suleimania and Suleimania that has the highest risk in the private hospitals more than 90% and in the public hospitals more than 50%. So, and who do you think are, Dr. Mahabat mentioned, and thank for her, she raised very important points about, I just wanted to brief that about the policy, the guidelines, then the implementation and monitoring of such guidelines. So what do you think, who are the responsible parties? Thank you.
Thank you, Doctora. I am من هاورام لقل دكتورة مهاباتها Caesarian section is a crisis now in Kurdistan. راستا كرايسيكي زور قورية بلام بداخل زور شت هيك زۆر جهت هەیە کە مەسئولە لێ بۆ نمونە ئەو فیگەرانەی کە دکتۆرە باسی کرد بەرزی کردەوە و هەمومان چاومان لێ بوو فیگەرەکان زۆر بەرزن بەڵام هەتا ئێستا نە کەس کۆنسێرنی ئەو فیگەرانەیە نە لە حکوومەت نە لە لۆکەڵ ئۆتۆریتی کەسێک هەتا ئێستا وەکو ئێمە پزیشکانی ژنان و مناڵبوون من لە ساڵی 2008ەوە بەڕێوەبەری نەخۆشخانەیەکی گەورەی مناڵبوون تێرشەریم هەتا ئێستا کەس یەخەی ئێمەی نەگرتووە لە حکوومەت بڵێ ئێوە بۆچی ئەم فیگەرانتانەوە نەهایە و لە ڕێزی نایە هەتا ئێستا کەس پێی نەوتوین ئێوە چ پلانێکتان هەیە بۆ ئەوەی دای بەزێنن ئەم فیگەرانە بەداخەوە لەگەڵ ئەوەشە یعنی کە ئێمە بێتاقەت بوون لەوەی کە پابلیک سێکتەر لەگەڵ پرایڤێت سێکتەر جیا نەکراوە لە وڵاتە چەند ساڵە نەتوانرا ئەو شتە بکرێ بەڵام لەگەڵ ئەوەشە لە هیچ مۆدالیتێکی دنیاە ئەوە نییە پرایڤێت هۆسپیتال بکرێتەوە ڕقم لە دوای ڕقم ساڵ بە دوای ساڵی چەندانەیە بکرێتەوە بەبێ ئەوەی هیچ سانسۆرێ لەسەر ئیشکردنیان هەبێ بەبێ ئەوەی کەس بڵێ تۆ چۆن لەسەر چ گایدلاینێگە ڕۆی تابتوانی ئەم هەموو سزەرێنە ئەەکەی یا ئەم هەموو سەرجەریەکەی من ساڵی پار داتای زۆر ئینسیستم کرد لە دایرەی سەحەکە داتای خەستەخانە پرایڤەتەکانم باتی وتم بۆی بزانم بۆچی ئەوە نەهایە چکە 2019 یەخەی مدیرعاممان گرت وتمان ئێمە وەرکشۆپێکەکەین لەسەر ئەمە ئەبێ لیمیتیشنی بۆ داینین بۆ سیزەریان سێکشن هەمومان هاوڕابووین لەگەڵەوەی کە کۆمیتیە دابنی بۆ کانسلینی پرایمیەکان بە تایبەتی ئێمە مشتی لە گەورەکەمان ئۆن د پرایمی لەگەڵ virgin abdomens who got previous delivery by normal delivery and they request cesarean section and those who are primary they are performing cesarean section on a virgin abdomen لەگەڵ دکتۆر سەباحە بڕیارمان ناکە کۆمیتیە دانین لەو کۆمیتیا کانسلینی پرایمەکانی تیا بکەین بزانین بۆچی داوای سیزەریان سێکشنەکەن طبعا ئێمە ناڵین ئێمە کەم و کورتیمان ئێمە وەکو خەستەخانە تێرشەرەکان لە هەر سێ محافەزەکە هەستەکەم کەم و کورتیمان زۆرە بە تایبەتی لە پێی لێز دلیڤەریە ئەو فیگەرانە کە وەرماگر لە پرایڤێت هۆسپیتاڵەکان و بەداخەوە کە ئەڵێم private hospital mainly they يعني depend on the gynae obstetric operations. Now gynae obstetric operations cesarean section is the most prominent, which is a disaster. So by this procedure we encourage the doctors, especially the young juniors, to do cesarean section more and more. Besides that ئێمە لە خەستەخانەکانە هەتا ئێستا پێین لێز دلیڤەریمان نییە وەکو وتمان هیچ پلانێکیشمان نییە بۆی ئەوەی کە کردومانە شتی زۆر هەمبڵ یعنی متەوازە بڵین گازمان پیا کردو بەس ئیپیدورال ئەنەستیزیا کە یەکێکە لە طریقە زۆر تازەکان بۆ ئەوەی کە خەڵک بتوانێ بە پێین لێز دلیڤەری مرتاح بێ لێی هەتا ئێستا نیمان لە خەستەخانە حکوومیەکان نیمانە و کەسیش کۆنسەر نییە لەبارەی ئەمەوە يعني ئێمە چەند زەخت بخینە سەر حکومەت سەر جیهاتی مەسئول هەتا ئێستا هیچ کەسێک نی و تۆ ئێمە محاولەکەین ئەم شتانەتان بۆ بکەین بێجگەلەوە ئەو ستافانەی کە لە نەخۆشخانە حکوومیەکانمانە بەرەو پیربوون ئەچۆن بەرەو ئەوە ئەچن کە ئیتر هەر مەجموعەیەکە ترینینێکی زۆریان کردووە و دلیڤەری باش ئەزانن ئەبێ خەستەخانە ئەهلیەکانیش ئەتیماد بکەنە سەر ئەوانە چونکە هەتا ئێستا هیچ خەستەخانەیەکی ئەهلیش هیچ پلانێکی نییە بۆ ترینینی تازەی ستافی تازە و خۆشتان نەزانن زۆربەی زۆری ستافەکانمان بەرەو تەقاعود بوون دەچن کەس نایەتە جێگا و کەس دانامەزرێ ئەمانە هەمووی نقطەن بۆ ئەوەی کە بێجگەلەوەی تین ئەیج مەرج لە ئاستی کۆمەڵە ینی کۆمیونیتیە تین ئەیج مەرج زۆر بۆ تین ئەیج مەرجیش خۆتان نەزانن لەژێر هینی میدیایە لە ناو سایتەکانە لە شوێنانە بۆیان باسەکرێت کە سیزەریان سێکشن باشتر it is the best way for delivery لەبەرەوەی پێینی نییە کورتترە ماوەکەی لەبەرەوە بە هەردوو لامان چ بە نەخۆش چ بە دکتۆر یعنی ئەو کارەمان پێخۆشە کە بیکەین بەڵام لە هەمان کاتە ئەمە بۆ داهاتوی وڵاتەکەمان زۆر خراپە دکتۆرە مەهاباد ڕژبینێکی پیشاندا من لەو ڕژبینترە بمەڵێم هەموو جارێ بە کۆلیکەکان وەڵێم ڕۆژێک گێت ئەبێ ساڵەی هیلادەکانمان داخین و ئەتیزار بۆ بەشەرێت و نەیچەر بێنینەوە بڵین vaginal delivery is a wrong route for delivery یعنی بەداخەوەڵێم ئەترسم ڕۆژێ بین بەو شێوەیە وەڕسکەکانیشی ئێمە ڕۆژانە ئەیبینین پلاسنتا پریڤیا کەیسمان هەیە لە 24 ساڵیە سیزەریان سێکشن هیسترەکتۆمی بۆ ئەەکەین لەبەرەوەی 4 پریڤیسە 5 پریڤیسە بەبێ پلاسنتا پریڤیا هێمۆڕێجی زۆرە بینین ئەنالیسیسی داتاکانی ماتەرنەڵ مۆرتالیتی ئەەکەین هەموو ساڵێ کە لە ئەنالیسی داتاکانە دەرەچی 75% بۆ 80% یان مۆدی دلیڤەرێکیان لە سیزەریان سێکشن بووە کەواتەمان زۆربەی زۆری کۆمپلیکیشنی سیزەریان سێکشنە.
زۆر سپاس دکتۆرە شلێر. As she mentioned, Dr. Schler, so the ownership by the Ministry of Health, by the decision makers, realizing that the problem is existing for many years, and it's time really to tackle it and to address it, and improving the quality of the service at the public hospitals. So they will encourage women to seek the care there. Also the training of the new generation, and then the handover from those senior people. So all these points need to be considered. Thank you so much. And now I will go to Dr. Haidar. He has extensive UN experience, and so I would like to ask Dr. Haidar, you just listened to the data and the figures and the challenges faced, and you know about them, I'm sure. So what should we do next? What's the way forward? How we address these challenges?
Thank you very much, Dr.
Thank you so much.
Basically, that I would like to revise some figures, which is spoken. Obviously, that our colleagues that they are mentioning that per government. We have the global data about Caesarian section. Caesarian section is not merely that locally that increasing only in Iraq and only in Kurdistan. But basically, this is a global trend now. Yeah. For example, now that in United States, Brazil, Egypt, Mexico, so many countries that their Caesarian section percentage around 50%, which is much higher than what we're talking about. If we go back for the figures, the official figures for Iraq from the mix 6, as the latest official figures available, Caesarian section incidence rate is 33%. Yeah. And if you go for the segregation data, Southern Center is 31 and KRG is 45. So obviously there's differences. Yeah. But if you before that we go for that, we need to go further, as colleague that mentioned, we need further analysis. Yeah. What are the roots for this crisis? Yeah. First, does it have impact? Is there any justification for it? So we have to look carefully about data. If we look for the previous mix 4, which conducted 2012, we can see that obviously there was big difference. It was around maybe 2% more than Southern Center. But most probably that for our analysis, why this rise, maybe because of because KRG, they hosted most of the IDPs, which was that year. And we don't know that. We have to look carefully about data before we make our judgment. Yeah. So basically, there are a lot of things to be considered. Basically, Caesarean section is not a bad thing. It's not. We cannot demonize it. Caesarean section is a surgical procedure, which is really that to save mother life or baby life or both of them.
A certain percentage.
Yes.
At certain.
I agree with you definitely. But at the end, if you go back to the patient right, this is part of who is taking decision that for the Caesarean section? Is it only the physician, or is it the patient, or both? There's a trend created by the society, and that's very important to educate people about the importance of Caesarean section. So we cannot say that Caesarean section, we are not encouraging it. On the contrary for that, UNFPA is trying jointly with Ministry of Health to support them to do further analysis about Caesarean section, to dig for the roots, the scientific roots behind it, and how we can help in decreasing it or keep it with the international level. Yeah. The international level, that which is addressed by WHO, which is between 10 and 15%. This is the official numbers. Once become above that, above 15%, there's something we have to look for it. Why that this increment happened? So basically, that there are so many reasons for this increment. They are not all bad reasons, but some of them definitely we can do better. Definitely we need to go further to improve the case, because with the Caesarean section is not 100% without harm. There are so many it's a surgical procedure, and it can happen. There are complications for these procedures. So basically that I would like to focus on the core of the discussion of this debate, which is who is taking decision for the Caesarean section. We are talking about unnecessary Caesarean sections.
Yeah.
There are some of them unnecessary procedures conducted. In many countries, the procedures that happen, that there's a protocol which is guideline issued by WHO regarding that the non-clinical interventions to reduce Caesarean section. I encourage Minister of Health sincerely to have a look at that guideline and to try to adopt some of their recommendations. Definitely nobody in the world that can do all the recommendations in that book, but they can pick what is suitable for them.
Yeah.
One of these, for example, in some countries, they go for mandatory secondary opinion. Always and whenever that, especially for emergency Caesarean section.
Yeah.
Emergency Caesarean section, which represent in KRG 70%, according to some research studies done by colleagues at Dr. Namir, Dr. Hamdiya, and others. They have that a lot of studies and research released here that in public journals.
Yeah.
And they mentioned that 70% of the Caesarean section is related to emergency Caesarean section, but we cannot say all of them really that couldn't be avoided.
Yes.
And also that, I go back again to MIG 6, which state very important fact, which is reflecting that there are a lot of unnecessary Caesarean sections, which is that they mentioned there is correlation between Caesarean section and wealth quantile. So it's highest in those wealthy people, and it's less with poorest people for the Caesarean section incident. That indicates that the private hospitals, they are the main contributor for this rise. We cannot say that statement clearly about that, but this is just analysis when we look to the data. Second thing, also that the educational level also is correlated with whenever that there's high education level, there is more incidence of Caesarean section. So if you go back, if you want to tackle these roots and these factors that which mentioned, definitely we need to educate people to have a look again before they decide, because not the physician only who's taking decision. Sometimes it's the urge of the patient. The patient, they want that. And now that the new generation, especially younger generation, they want painless delivery.
1 minute.
Okay, they want painless delivery. Painless delivery, it's a right, okay?
Yeah.
But there are other procedures.
Yeah.
There are so many clinics around the world that painless, this is one of the recommendations that we can issue. Instead of going for the Caesarean to avoid the pain, we can open clinics for painless delivery or centers for painless delivery. Also, the second very important thing, that we have shortage in nursing staff and midwifery staff. We need to address the issues to improve their performance, to train them and to support them. And these things, I think that still there's a lot of things to be done in this area. And UNFPA is working very closely with ministries to help to improve the midwifery, because we need to compete to have additional options for them.
Yeah, they are there, we have to use them in proper way.
Yes.
Thank you so much, Dr. Haidar. You highlighted very important points. Yes, as we said, it's a global problem, not only in developing, it's also in developing countries. And as it was said, yes, it is a decision both by the patient and patient condition and the doctor, but should be informed decision, as we said. And also training of the midwifery, training of the nursing staff. Also, I always say that too many researches are done. But here, I think there's a challenge for the new Director General of the Planning to really use these researches for action. Too many researchers, but they are there and somewhere so you have to search. But these researchers and further assessment should be done. As you said, we need to know. It's just a number we have. We want to know details, why they are so high, what are the causes, what's the emergency, and if we have research, we can better use them for the next steps. Thank you so much. 2 points, okay, because I give you 2 minutes, I want to go to...
We are here to put the point, and globally increases in section rate but we are here to decrease non-medically indicated. And every locality يعني همو ولايات الدنيا هريكا general cause هي كباس ما كرت maternal age infertility عمرك جورة المضالي عندها medical disease استزور diabetes hypertension بس أويدي locality أو أملا locality خمان دبينين دبي أوي تابكين يعني أو ظاهرة شزقة فعلا ليركوانين بيشكا يعني وكوبانا لك بعض ذكين لبروي دمانوي practically حالين كين لهم بوينت كامل هم ترى وقت ما يعني باسي دكتورة شليرج باسي painless labor كانت أودو لأنا دكتورة أود يعني يكمل مستشفيات أهلي حكومي نيرسينج سيستم بقوة بكرة ليبر كان سكيلي ليبري زيادة اهتمام بيبدري زيادة كورسات فندي لو ترتيب بكرة زيادة اهتمام بيبدري لا أنا نخش خانة برايفت كانيش دبي وكدكتورة باسك دبي كونسلينج كوميتي نابي مستشفى أهلي دروس بكرة كس حقيني بس هيت عمليات اللي ذكرتي اللي ناكا بس الطريقة ذكرى يعني الدنيا وانية يعني نابي وهاوي يعني دبي كوميتي دروس بكرة دبي كونسلينج كوميتي هبي دبي جايد لاين هبي الهم مش مهمتر تخرج ذكاء يعني شتشخين دي النسائية طبعا نمارسي نسائية بهج نخوش ودنا خوشي لبرايفت بروجة شرير ذكاتن ممارس كحقينية لهي الدنيا لقليم كردستان برو دري هيت ممارسة ناتوانيشكا نابي أوا الدكتوري فاميليا إيش ذكاء يعني أوانية مدماني متسابقين.
أوكي. تمام. دكتور معبد. زور سباس. Okay, I just quickly, as Dr. Mabas said, we said the quality services at the public hospitals and thank you for in regards of provision of painless labor, of capacity building of the skilled labor attendant staff. Also, I also emphasize that to have a policy or the committee as it's existing in the public hospitals, a second opinion, so any surgical operation is Caesarian section is done in the private hospital, as is the case in the public hospital, should have a second opinion, should have a committee, and these are really challenges for the Ministry of Health and the decision maker to work on it. And now, thank you so much for the panelists. I have only, I think, 9 minutes. I will start to take questions. First question from Dr. Kochar, please.
کوچر شیخانی ل سکولی پزیشکی زانکوی کوی زوزو سپاس لو زانیارکانتان بسیارک بو دکتور مهابات و دکتور شلیر اگر وکو ویکا اکید یعنی کلینیکا بابرین عیاده خودتان تنه یا خود لنخوش خانه کان دام دکن اگر زالیاریتان هبی جیاوازی سیزیریان سکشن لجنانی آنی کنیشت زی شارن زیادتر یا خود لجنانی آنی لا بابن قرآن اریاف دادن نشن دروی شارکان وكو استا اگر او جیاوازیتان کرد بی بزانی سیزیریان سکشن لکامیان زیادتر وانەی کە دانیشتووی لادەیەکانە یاخود ئەوانەی چونکە ئەوەی کە من هەستم پێ کردووە بۆیش ئەو پرسیارە دەکەم لە ساڵی 2016 گروپێکی بچکۆلانەی کۆمەڵێک با بڵێن خوێندکاری پزیشکی بوو بڕیارێک نازانم بۆ ئەوە بە مێشکم داهات environmental effect on Caesarian section شتێکی گچکۆلەکەمان کرد سەمپڵ سایزەکەمان وابزانم 6 دانە بوو زۆر کەم بوو دواتر ریزڵتەکە وای نیشان داین ئەوانەی کە لە با بڵێن ناوشاردا دەنیشن زۆر قابلیەتی ئەویان تێدایە زیاتر تووشی با بڵێن بڕیاری سیزیریان سەکشن بدەن و هەتا ئەوەی کە لە سەرەتای دووجیانەکەی خۆیەوە بڕیاری دابەوەی کە من عەمەلیات دەکەم دوایە بەبێ ئەوەی هیچ ئیمەرجەنسی بی بەبێ ئەوەی پێویستی پێبی هەر لۆ خۆشی خۆی بەس لۆ ئەوەی دوور بکەوتەوە لە ئێش و ئازار نەشتەرگەری ئەنجامدا نەک ئەوە تەوا بڵێن بەر لە ڕێگەی ڤەجینەل دیلیڤەری قەراری لێ نەدرا ئەمە لەبەرەوەی سەمپڵ سایزەکەمان زۆر کەم بوو نەمانتوانی ئەو کات پەپلیشی بکەین و بە شێوەیەکی ڕێکوپێک ئۆرگەنایزی بکەین ئەگەر نا ئێستا لێرە دەمتوانی پێتان نیشان بدەم وەکو خۆتان ئەگەر فکرێکتان هەبی لەسەر مەسەلەی ڕورال ئێریا و ئەوانەی کە لەناو سەنتەری شارەکاندا دەنیشن ستانیان زۆر سوپاس
هەر یەکەمان باسی ئێریای خۆی بکە من بەڕاستی پێش چەند ساڵێ لەمەوە پێشلەیەکێ لە دیستریکتەکانی سلەیمانی بەداخەواڵێم لەبەرەوەی هیچ مۆنیتەرێکیان لەسەر نەبوو لە ڕێشوی سزارین سەکشن لە ناو public hospital گەیشتە 80%, which is a very big number. دوایی ئیشمان لەسەر کرد کەممان کردەوە بەڵام by now there is no difference between the ruler and the inside city. ئێستا حالیان بەعکسەوە هەندێک جار ڕوڵەرەکە زیاتر داوای سزارین سەکشنەکە. نازانم ئەکسپیرینسی هەولێر دکتۆرە مەهاباد چۆنە بەس لە سلەیمانی بەو شێوەیە ینی the same ناتوانین بڵێین زیاتر لە ناو شارتا لە دەروی شار. خۆی وەکو دکتۆر حەیدەری ژووتی لە لۆ لێڤڵا زۆرە لەگەڵ هایەکانە لە هەردوو لێڤڵەکە هەیە.
بله زۆر سپاس دکتۆر مەهاباد چۆکتێ
بەنسبەت ئەوەی هەولێر و کەنتری سایدەکانی هەولێرێ وەکو دکتۆرە باسی کرد ئەمە ئەو ڕێژەیە ئێمە تێدایە معقەترە یعنی مەسەڵەن با بڵێین ئەسبابی وازح هەیە ئەسبابی خێر وازحیش هەیە یعنی وەکو ئەوانەی کە ریش پیپڵن ئەوانەی کە پور پیپڵن پور پیپڵەکان عادەتەن یعنی لە دەرەوەی شارن بەس ئەو ڕێژەیە ئەمە وەکو متابعەمان کردێ لەو چەند ساڵی داهاتوو کە تەنسیقمان هەبووە لەگەڵ مستەشفایەتی مەسەڵەن سۆرانە شەقڵاوێرە و جیانەیە ڕێژەکان زۆرترن هەندێک زۆرترن لە هیما لە ناو شارەوەی هەولێر لەوەی لە هەمە لە ناو هەولێر با بڵێن باسی مستەشفای دەکەم ڕێژەکە کەمترە لەبەرەوەی علمی زیاتریش لەسەر دەکرێت بەس بە ڕفێر زیاتر لۆ ئێمە دێن بەس ئەوەی یعنی بە شێوەیەکی گشتی ئەوە پێویستی بە زیاتر تەسقیفکردنە.
زۆر سپاس دکتۆر ڕۆژگار. دکتۆر ڕۆژگار.
Thank you very much.
Yeah,
sure. Thank you very much for this panelists and the dear the moderator.
Thank you.
So the thing is that the main problem in terms of cesarean section in the private sector, in the clinics. So my question is that, as we all know that preparing the lady to give birth, the birth plan is not only the physical checkup. During her checkup to the clinic, it's not only measuring the blood pressure, the weight, sending some CBCs and things like that. It's the mental preparedness. You're talking to the lady for an entire 9 months, and then all of a sudden, going to the hospital, you want to convince her and negotiate with her to do it by normal vaginal delivery. It's impossible. It's impossible. So my question is that, what will be the route if you think it's feasible for the gynecologists and obstetricians to practice this mental preparedness? I'm sorry to say that, please forgive me, but to me it's kind of a fishing. It's like just throwing a net on the patients just to have as much as cases that you will prepare to, to divert it to do the cesarean. And to me, the public hospitals is becoming just like a tertiary center for referral for the most complicated cases, which we cannot do with the cesarean in the private hospitals. And thank you so much. And just one answer, Dr. Haider, for you. You asked about whether the IDP populations, the cesarean section, is increasing. It's true that the IDPs and refugee communities within the camps have a higher fertility rate in regard of other population. But in terms of the proportion, it is increasing. So we are teaching them to think of cesarean section, unfortunately, and thank you so much.
Thank you so much. Okay, who want to answer?
May I?
Yes, please,
Yes.
Dr. Haider.
Thank you very much. Dr. Rojga, thank you. You tackled very important points, in fact. In fact, that one of the main recommendations that we are always talking about when we talk about cesarean section incidents, we are advocating Ministry of Health to develop counseling guideline for just like what we did for family planning. Also that we need to do that counseling guideline for cesarean section so that the lady, before that she decide, because as I mentioned before, the decision is not only for the physician sometimes, that if the lady she refuse or she don't want, nobody can convince her with that. It's the patient's right. But at the end, it's decision of both. They prefer that maybe based on misinformation or some affecting by the trend of the society, whatever that the reason. So to solve this issue, that we are highly recommending that developing a guideline, we are ready to support with that. But we need the decision to come from the Minister of Health. We are ready to support, to develop the guideline for counseling for cesarean section, so that to aware her about the choices, about the risk, to informed counseling. In this case, that they can't take decisions. You know, everyone that have relative and you hear about precious baby, which is that they are afraid about it. Yeah. I don't know where this concept came from originally, from the society or from the doctor's society. So that basically that to convince them that this is the safest method, that this is misconception in fact. The safest method is the normal delivery when there is no risk.
Yeah.
So basically there are so many things that we need to address it, and it could be solved with this way. Thank you.
Okay, thank you. Dr. Rondik Hawez.
Hello everyone. Thanks for these nice issues that are raised by you. I'm Dr. Rondik Ahmed Hawez, Head of Department of Nutrition in Hawler Medical University. Actually, Dr. Rojgashi raised some of these points that I wanted to raise as well. The role of gynecologists and obstetricians, they are very, very important in declaring the risks for the after C-section or for the patient, as we know that in our society the individual's educational health education unfortunately is low. That's why it's very important to declare for them the risk for C-section. As I noticed that those gynecologists, in my experience, they talk more about the risk of the vaginal delivery instead of the risk of the C-section. So, and also as I belong to the nutrition, it's very important for the newborn for breastfeeding, and most of these women after C-section, they cannot, they face difficulty for the breastfeeding. So I think the gynecologists need to advise the mothers for the risk of the, and to talk about the risk of the C-section and the
breastfeeding.
And also the beneficial of the normal delivery and the breastfeeding for the baby in future.
Okay, thank you. Thank you. Do you want to answer or I comment? Okay. I think we cannot. I don't know.
It's an explain.
I think it was the same, like preparing the women mentally, telling them about the risk of the Caesarian.
And both of them blame gynecologists.
Yeah, I think I have to say something. We don't have to generalize any issue. Yeah, because we cannot say all gynecologists, all obstetricians. So we don't have to generalize.
This issue.
Yeah,
this problem.
you have to have based on data. When you say that they are, for example, they don't know, obstetrician talk about risk of vaginal delivery more than Caesarian, we have to say these things based on data, actually. So if you have data, then we can raise this issue more.
In the point, it's the responsibility of all 3 to 4 lines, as we said in the start. Yeah. Obstetrician, patient herself, the government, the public, private hospital, these points. But what's important here, in every subject, in every problem, in the broad, what they did, the protocol, as Dr. Haider said, the guideline and protocol can manage everything in the 70%. Yani in this century, you should think. Yani every doctor me a gynecologist and the other gynecologists, in 70% in managing the case, you should think the same thought. يعني management case كان مان لسطح حفتاي دبي هم وان وشي تقريبا هم ما صالنا وكو يكتري شتنوي كان بزانين بس سطاسي دقرته ولا skill ولا experience ولا وشتانا كواتم بروتوكول لاناني بروتوكول
policy protocol guidelines
نخوش لسيو دوي كوا counseling دكري نخوش لسيو ششوي كوا counseling دكري نيرس چلو دادن دري اتصالي پیدا بيجو دكتورة كبيبيني فيرا اللي بدي دكا فيرا how to manage herself one-to-one care هبي يعني أنا هموي ببروتوكول حل ذكري لو إما باس مانكر أما يعني وكو gynecologist دكتور شلير أكيد لقلمنا همو ما حاضرين و پێویستیشە پاز ئەو پەنەڵەی میدیا پێش هەمووانە لەوەی شەکان بکرێن خۆش تەسقیف بکرێ دووش پرۆتۆکۆل دابدرێ لە مستشفایەتی ئەهلی پێشۆیە منالێن ریکوێست سیزارین سێکشن نەخۆش حەق خۆیتی بەس پاژەوەی هەموو شتێک تێدەگەێنرێ ئەو جاو کاتی she's free.
Okay. Thank you so much. Yes, yeah. I think I'm running out of time. Can you give me 10 دقيقة? But we started late. No, just we have more two questions and we bit started late. Can you? Okay, just two questions more.
I have one statement.
If you allow me.
In fact, that most of the time that we, as health professionals or the society, we hear that they segregate between the doctors' society and the community. In fact, that we are part of the community. We are not different community. So when we said that we are imposing for a specific culture, we are also affected by the culture. Yes. So in fact, that is the overall trend for the culture is driving both the patient and the doctor. That's
yes.
right.
As we said, it's, women, mothers, units, they are equal to community. So the first question from Dr. Sadiq Aziz Khoshna. Dr. Sadiq.
Thank you so much for all of you. My name is Sadiq Aziz Khoshna. I'm a general surgeon in Hawlir Teaching Hospital. Actually, I have a few points. First of all, it's not only for cesarean section, actually. It's true for tonsillectomy, it's true for non-indicated laparotomy, it's true for appendectomy. So I will jump to the second point. It is the health system. So both gynecology surgeons and the patients, they are part of this health system. So it has the impact directly on both gynecologists and patients. Third point, the health education is the most important point, the health education. I remember I was a house officer in maternity hospital. I saw one of my mentors, my teacher. Actually, he was a university teacher. He brought her wife for cesarean section, and I asked him, what was the indication? He said that just I want a painless labor for my life. Yeah. I love her. I love my life. So just this point. So health education is actually the health. All of us, the community, as Dr. Haider said, we are part of this community. So we need.
Yes.
And finally, fourth point. I am with Dr. Kocher. I noticed that rate of the cesarean section increased with the quality of life. How much the luxury of life, how much the cesarean section is increased.
That's why
Thank
you should
so much.
be informed and counseling. Last question from Dr. Ammar.
Thank you, Dr. Jiman and all the panelists. I think my question has been covered by other questions. I will just go very quickly and save your time. I am Dr. Ammar from the University of The Hague. I think Dr. Rujgar, I am not wrong. Yeah, I'm sorry for the name. Yeah. So she has focused on the counseling by the doctor. Yeah. Dr. Haider said that it's a global trend and it's increasing everywhere. But because we are focusing on our community. So just very quickly, that I think the patient education in the clinic, in the private clinic, by the doctor, by the gynecologist, to educate the patient about the complications, risk associated with the cesarean, and also what are the advantages of the spontaneous labor, vaginal labor. So because these patients are attending clinics every month, so you are meeting the patient maybe 9 or 10 times during the gestation or pregnancy. So it's very important to explain these points. And I think in this hall you have many gynecologists. So if I am not wrong, some of them, if not many, are trying to motivate the patient towards cesarean section, whether financially or something else, okay? So apart from the guideline that Dr. Haider said that they are going to put some guidelines for that, just personally, patient education in the clinic every month about these complications and advantages of the vaginal labor will help and will decrease the rate of that. Thank you very much. Thank you, everybody.
Thank you so much. Thank you for everybody. Just in closing, because I agreed that our panel should end with a set of recommendations. So first, the ownership by the decision maker, to have a policy, clear policy for the public-private hospitals, to have guidelines for counseling, for management, to have informed decision, to have second opinion for Caesarians, especially in the private hospitals, to improve the quality of services at the public hospitals, to increase the capacity building of the skilled birth attendants, the painless labor, all these issues. I don't know if I have covered everything. I hope this, if in the next summit or next conference, I hope we have taken action on this one and we collectively reduce the unnecessary, unindicated, medically indicated Caesarean section. Thank you for all. Thank you for the panelists. Thank you.
Thank you.
I want to thank the panelists. Thank you. And our dear guests, you can join us in the coffee break right now, and please be back inside the halls by 11:55. Thank you.